And that's why we have these conferences and courses to share everything. Because the basic values of Project ACL is to be open, transparent, including, we want you here. Positive, friendly, we should have fun too. And we had a lot of fun last night with Eric and Andreas. And sharing. Now we're sharing all our thoughts and for everyone. So that's why we have this Congress. And we invite the next speaker to come up. I think it's Christian. Welcome up, Christian. Time to go.
So, probably hear me better now. So what's new? What do we do in ACL research in Gothenburg, or knee research actually? What is happening? What are we thinking? Well, I'm going to talk about it later on because I have a slide on it, but it's lateral extraarticular tenodesis. Oh, forgot this one. Thank you, Greta. So I don't know why she's looking there. So anyway, we're going to talk about it later on. Exactly. So, and it's lateral extraarticular tenodesis. You're going to talk about it much more. You're going to hear about it much more. What it is actually an old technique that resurfaced, which means that what you do is you put an extra. All these different techniques I'm going to show you. You put some extra stiffness or stability on the lateral side of the lateral compartment. So we did this in the 70s and 80s before the intra-articular ACL reconstruction. So people didn't do ACL reconstructions. They did lateral extraarticular because they thought that was the case, the injury was on the extraarticular side, until they realized, wait a minute, we have to, fix the ACL. And it was done by Dan in the 80s. After that, it just died away. Nobody did it in the larger countries, except in the French and the Italian. They always do stuff weird. So they continue to do it and develop it. And now it resurfaced by a couple of years ago by a Belgian guy who thought he found a new ligament, which he actually didn't. And that's something else I'm going to talk about, the rise and fall of the so-called ALL ligament. The other thing is quadriceps graft. Jay, is he gone now? Yeah. To just take over and be the gold standard. A lot of people did put a quadriceps tendon. It just went away. Nobody did it for a long time, except the French and Italians. They always do weird stuff, as I just said. And now it's being popularized again. People are writing columns and so on, and talking about the forgotten graft, the quadriceps graft. Why is it so important? Well, it's thicker than the patella tendon. You can measure it. You can use a bone block or not a bone block. And with newer techniques, with newer sutures and so on, you don't have to use full length, and you don't have to do full thickness. So it's getting more and more popular. People are doing it much more. Still not as much as hamstring tendon. So that is new stuff and new research we're doing. So in Gothenburg, we're starting up a multi-center study with a huge number of multi-centers in the world. What we're going to do ACL reconstructions with quadriceps grafts, lateral extraarticular and other stuff, and measure what's the differences, is it any good, when should we use it, and how should we use it. Eric, you said 5 minutes, did you?
Yes.
I think I'm there. Yeah. So who's next?
Okay, so hi everyone, good morning. My name is Eleanor and I'm a PhD student and a medical doctor currently doing my internship at Sahlgrenska on my off-day chance. So let's talk about the Scandinavian registries. What have we learned? They have been established for more than 10 years now. The Norwegian was first out in 2004 and the Danish and the Swedish followed a year later. And when studying the registries, we primarily used three outcomes. The event of an ACL revision, the event of a contralateral ACL reconstruction, and the patient-reported outcome, where we primarily used the KOOS, the knee injury and osteoarthritis outcome score. And a while ago, we decided that we wanted to summarize all findings published from the registries in relation to these outcomes. And this resulted in 2 systematic reviews published in the British Journal of Sports Medicine. And as you understand, it would be truly mission impossible to try to summarize this amount of studies in 10 minutes, but I'll present some of the most important findings that we identified. And I have indicated throughout the presentation with the national flag from which registry each finding was reported. So let's start and talk about revision. ACL revision, if it occurs, it tends to occur early, within the first 2 years of primary surgery. And these are numbers from Norway and Sweden showing that the general revision probability is low, ranging from 4 to 6% within 7 years from primary surgery. But it's important to remember that these are the general numbers and that some subgroups of patients are at a much higher risk. And one factor increasing this risk is young age. A 5-fold increased risk has been reported for the youngest age group compared with the oldest. And this figure illustrates this well, the high growth survival for the oldest age group seen there at the top, and then it gradually decreases by age until the youngest age group seen here. So young patients are at really a severely increased risk for revision. Another frequently discussed factor for revision is patient sex, but interestingly, no study from Scandinavia has ever shown that patient sex influenced the risk of revision. These are numbers from Sweden showing that a majority of patients undergoing revision are males. Looking at the relative risk though, females perhaps tend to have a slightly higher risk, but still the difference is not significant. One study, however, has reported that when combining female sex with other high risk factors such as playing soccer and being under 18 years old, females have an increased risk compared to their male counterparts with the same risk factors. So there might be a difference. And then what about the graft choice? We discussed this yesterday, and as you remember, hamstring tendons are by far the most common graft choice in Scandinavia, followed by the patella tendon. And 7 studies have compared the outcome or the risk of revision between the grafts. Of these 7 studies, 4 studies reported an equal risk for revision between the grafts, while 3 studies found a lower risk for patella tendon. And patella tendon has been reported superior, especially in young age groups, and to avoid revision within the first year. So why would a hamstring reconstruction increase the risk for revision within the first year? Well, we don't have data on return to sports in the registries, but it is possible that one explanation may be that the longer healing time for hamstrings. An early return to sports, perhaps before complete healing have occurred of the hamstring tendon in those patients, may have contributed to this finding. And then we must also consider the variable graft diameter, as Christian discussed yesterday. The hamstring tendons are variable and very patient dependent, while the patella tendon is much more uniform and harvested in standardized fashion with about a 10 millimeter graft width for almost all patients. So we must ask, does size matter? And in this case, yes, since it has been shown that for every 0.5 millimeter increment in hamstring graft diameter, the likelihood of revision decreased. It decreases by 14% for every 0.5 millimeter increase in graft diameter. And another published study from our team showed that there is no difference between hamstring and patella tendon in terms of risk of revision when adjusting for the hamstring graft diameter. So likely there is no single answer to the ultimate graft choice, and ultimately individual factors play a bigger role and should be considered when selecting graft types. And also more and more quadriceps tendons are being used in Scandinavia, so hopefully shortly we will have enough data to study also these patients. So that was revision. Let's move from revision to contralateral ACL reconstruction. The identified risk factors for a contralateral reconstruction have several similarities with those of revision. Again, young age increases the risk, but for contralateral injuries, it seems that there is a difference among genders, as females has been reported with approximately a 30% increased risk. And females are especially at risk if a contralateral hamstring tendon harvest to use that graft in the primary surgery is performed, resulting in a threefold increased risk for females, which has not been shown for males. So perhaps contralateral hamstring tendon harvest should be avoided. And then finally, the patient-reported outcome. What have we learned so far? If we were to summarize positive predictors for a higher KOOS after ACL reconstruction, it would look like this. Being male, of young age, have a reconstruction of hamstrings, have no concomitant injuries, not smoke, and have higher preoperative KOOS are all factors associated with a higher patient satisfaction after surgery. But the interesting question here is, do these factors lead to a clinically relevant difference? Meaning, do these predictors lead to a higher KOOS score of that dignity that we can conclude that these patients actually feel better? A recent study from Norway aimed to determine this, it aimed to determine the meaningful change in KOOS. And it concluded that the KOOS subscale sports and recreation and quality of life are preferred as the primary outcomes. And the MIC values, the minimal important change in these two subscales, these are 2 of the 5 subscales in KOOS. They were 12.1 for sports and 18.3 for quality of life. So with this in mind, let's go back to our positive predictors. Here I have listed the maximal difference that any study reported for these in the sports subscale. So for example, the maximal difference between males and females, a 2-year follow-up, was 4.4 points. And as you can see, all those significant findings, significant positive predictors, they seem to result in quite small and perhaps not clinically relevant differences. So based on the findings from the previous study, it seems that a higher preoperative KOOS, maybe in this case was the only factor that had a meaningful impact, resulting in a mean 17.7 points higher KOOS. But this is important because this is something that we can target in the preoperative care of our patients, making sure that the knee function, the perceived knee function is as good as possible prior to surgery. And the study reporting this was a study from Norway that compared data from a special intervention population, the NAR cohort, patients that underwent structured pre- and post-operative rehabilitation at a specialist clinic. They compared these patients to patients that, control patients that received standard care in the Norwegian registry. And what is standard care? Well, we don't know anything about the rehabilitation, that's what it means. But anyway, as you can see, patients in the NAR cohort here reported higher preoperative KOOS in all subscales, and a 2-year follow-up, they still reported higher KOOS score with a maximum difference of 17.7 in the sports subscale. So this is one study, this is a quite small study, but as you soon will hear from Eric later in this session, from the first 10-year follow-up of the registries, a higher preoperative KOOS is actually associated with a better patient-reported knee function as long as 10 years after surgery. So, what have we learned from the registries? Well, we must acknowledge that young patients are at a severely increased risk of both revision and contralateral ACL reconstruction, and they tend to occur early, and we may be more observant among females participating in pivoting sports, since it has been shown that they have an increased risk, and the effect of graft choice is multifactorial. But taken together, it means that we need individualized treatment and individualized return to sports criteria while considering these factors. And finally, a better preoperative knee function and KOOS outcomes. So we should strive to getting our patients as prepared as possible prior to surgery. Thank you.
Thank you. Is this on? I think so. You're nodding your head. That's good. Thank you, Eleanor. Great breakdown. So now let's hear what Jon Karlsson thinks about the future of the Scandinavian registries.
Christian Fullborg said yesterday that why do we not need the registries? Eleanor had a very good answer here. We can use the registries to find out about individualized treatment. Also last slide, great. Second, KOOS score, is it a good tool? Nobody said yes. Okay. I think it's, KOOS has developed two things. WOMAC, the 3 scales on the left, and 2 new scales on the right. And the 2 new scales on the right, they are responsive for ACL and meniscus patients. But the other 3 scales on the left of our KOOS picture, they are really made for patients with osteoarthritis. This may be a complete picture, but for an 18-year-old, it may not be that relevant if you can put on your socks. I don't know. What do you think? Am I right or wrong? Yes? What is that? Okay, future. Yes. Thank you for inviting me to be here with you this morning. So, the ACL registries that we started in, it's a kind of a joint venture in Denmark, Norway, and Sweden. Finland doesn't have any registries yet. They talked about it for years, but they have not come forward. Norway was first, started in 2004, Sweden and Denmark in 2005. And together, the registries comprise data from more than 70,000 patients. We add about 7,000 to 8,000 patients every year, and there are more than 70 studies published, and there's an increased number of studies being published the last years. So the main strength of the registry is that it contains a large patient sample, and it's a representative cross-section of the real world. The problems we have from day to day, etc., we try to solve. The registry studies, they are case-based cohort studies. We don't decide on the hypothesis on beforehand, collect a lot of information, and then you create the hypothesis and the research question afterwards. They are very good in determining the rate of adverse events and, for instance, to develop new strategies and to drop, for instance, grafts or methods that have not been that good, because the registries, they show that very well and fairly quickly. For instance, the hip replacement registry. The hip replacement registry, we worked with it at our hospital, at our university for almost 30 years, collected 400,000 patients. Problem is that the registries, they do not prove any causality, they are hypothesis generating. So recently we started to work on patients who have not undergone ACL reconstruction. And until now, there's only one study published. We are working on further studies, and the main challenge is that we must increase the registration of non-reconstructed knees. We must understand what happens to them and why there's an indication not to perform an ACL reconstruction. And thereby we could understand who could safely be treated non-surgical. In the one study we have, the results are worse for non-reconstructed patients compared with reconstructed. However, the difference is not huge. So it will be very interesting to see what happens in future. So there are some planned studies to identify factors for good and poor outcome. What characterizes patients that cross over from non-reconstruction to reconstruction, and why does non-reconstructive treatment fail? And we need to compare outcome between non-reconstructive patients and patients undergoing ACL reconstruction. Another thing that we are working on, and in the registry, we are actually working in a multi cultural environment, and working together in a big group in Europe on pediatric and adolescent patients. And as Eleanor mentioned here, the young ladies, they are the patients who have the biggest problems. The revision rate is not fairly high. It's not very high by and large in a group of young males who are go back to play football. The revision rate is maybe 3 to 5% in a perspective of 5 years. It's not terrible. But we need to study the pediatric patients, the adolescent patients. And recently we published actually in 4 journals at the same time a consensus paper that we did together with Lars Engelbrecht and his group at IOC in Switzerland, and about the consensus how to evaluate, how to treat, and how to follow children and pediatric population with ACL injuries. It has been shown that ACL injuries among young patients, they increase. And there is a debate whether we should operate or not during growth. The plan studies is to, or what we will be doing in something we call PAMI. It's a European collaboration of network that was initiated by ESCA, and we are working on this, and we will publish several studies from this network for the next years to come. One important question is whether pediatric and adolescent patients who sustain an ACL injury make it to elite level sport. We don't know this. And is it safer to operate on them even when they're 11 or 12 years old or not? And we need to combine data from the registry with administration of survey that has been done under the umbrella of ESCA to check on the activity level of these patients. Another thing that where the registries will be very helpful in the future is about graft choice. Eleanor mentioned about hamstring versus patella tendon, and we know a lot about this, and there have been several good randomized control studies. They have not shown very big differences. We know fairly large the pros and cons of hamstring versus patella tendon. We also know that we should use a larger hamstring tendon than we have been using. So 7 millimeters is probably not good. We should increase it to 8, 8.5, or maybe 9 millimeters. What we see is that there have been more and more ACL reconstructions performed using the quadriceps tendon, and this is something that is new. However, there is no study so far from the registries that investigates outcome using quadriceps tendon. Quadriceps tendon can be a very, very good substitute or equal to using the patella tendon, but we will probably not have the donor side problems from the front of the knee, and we'll be able to kneel and squat. We will soon have enough data to compare the effect and efficiency of the quadriceps tendon compared to the tendon grafts. Another thing that lies in the future is meniscal transplantation. This has so far rarely been performed in Scandinavia. Data from other geographical areas, from for instance Central Europe and especially US, show very promising results. So we foresee that meniscal transplantation, and we can use allografts. We can also, at least theoretically, use the patient's own semitendinosus tendon that we fold 4 times and create a new meniscus. And this is something that has been done recently by Carl Eriksson in Stockholm with very promising results. And we foresee that this will be more frequently done in future. Another thing we mentioned yesterday, just very shortly, is registry-based RCTs, but to randomize patients to treatments within the registries, for instance, nationwide. And this is doable. However, This requires some structural adaptation of the registries, and there are methodological challenges with securing data quality. We have recently started more and more to collaborate with other registries, and we collaborate quite a lot with Australia, New Zealand, and especially with Kaiser Permanente Foundation in US. Kaiser Permanente covers about 10 million people in US. It's about the same as Sweden, and they have a registry that's very similar to ours. And we have started to publish together from these registries. And this is very interesting to see the differences in US compared with Scandinavia. And they actually have the same things that they are happy for, the same things that they have the problems with. So this is new, and this is something that will come. We have not started to work with Moon and Mars in the US. These registries are different. They are based on surgeons, and they are based on a complete follow-up of the patients. They are followed with X-rays and MRI, and every patient, so they have more than 90% follow-up, even up to 5 to 8 years. This is something that might lie in the future. Okay, thanks.
Thank you, Jo. Next on stage is Susanne, who will speak about adolescent patients and a lot of the results from the thesis being produced or being written currently.
Yes, thank you, Rick. So now we have heard a lot about the risk of adolescents and that they are a high-risk group. So that's why I started my PhD. And so why adolescents? And this is why. They represent the highest group, as many other talkers have mentioned here. So up to 30% of the patients will sustain a second ACL injury once they return to sport. But I would like to start here. This is the age distribution of the patients included in Project ACL. And as you can see, we have included patients from 9 years old, and this is the age of the primary ACL injury, how old they were at the primary ACL injury. From 9 years up to over 65. And previous studies, they include patients mostly from 15 up to 50 years, and with a mean age about 26, 27 years. And it's true for our project as well. The mean age is about 27 years of age. However, we have a large proportion of patients here. 25% is in the age between 15 and 20 years of age. You can see this peak here. So why if they are different? If we need to treat them differently? Maybe we need some different return to sports criteria. We know that the young patients, they have a higher return to sport rate. Up to 80% of them return to pre-injury level of sport, compared to 65% of the adult patients. And we have talked about this. We know that a premature return to sport before 9 months, will increase the risk of a second ACL injury. And patients with more symmetrical muscle function prior to return to sport, they have a lower risk. So the main question for me was, why are they a high-risk group? Can we find anything that we can describe why? So we started to design some studies, and this is the 3 that I've been some results from. And these studies, they were all based on data from Project ACL, and we included the patients if they were between 15 and 30 years of age, and if they were considered as athletes. And with that we mean that they were involved in knee strenuous sport before the injury, and we define that as having a Tegner activity scale of at least 6. And they had all a unilateral ACL injury and had underwent reconstruction. And we defined adolescent athletes as being between 15 and 20 years of age, and adult athletes being between 21 and 30 years of age. And in all studies, we define symmetrical muscle function as achieving achieving an LSI of at least 90% in all 5 tests of our test battery. So the first question was this. We know that symmetrical muscle function seems to be protective for a second ACL injury. So we asked ourselves, how many of the patients that already are involved in knee strainer sport actually have achieved symmetrical muscle function? So we compared adolescent athletes with adult athletes at 8 and 12 months after the ACL reconstruction, with respect to the rate of return to knee strainer sport and the proportion of patients achieving symmetrical muscle function in the patients who already were involved in knee strainer sport. And this was the result. At 8 months, and note that this is before what we have defined as a premature return to sport, at 8 months, half of the adolescents had already returned to sport, compared to 38 of the adult athletes. At 12 months, there were a difference, but not a statistical significant difference. And in the patients that had returned to sport, only 29% in each age group had recovered their muscle function, had achieved symmetrical muscle function. And at 12 months, it was even worse. It was 20% of the adolescents and 28% of the adults. And there were no difference between the age group. So some patients, they achieve symmetrical muscle function, and some do not. So we asked ourselves, what predicts the achievement of symmetrical muscle function? And we used all these variables here as potential predictors. It was the patient's demographics, such as age, and sex, and the results from the 5 tests of muscle function, and 2 patients' reported outcomes. As potential predictors of achieving symmetrical muscle function at 12 months, and these were conducted at the 4 months follow-up. And this is the result, and I will try to explain it for you. None of the patients' demographic were found to be predictors of the achievement of symmetrical muscle function. That means there were no difference between male and females, or between, for example, the age groups. However, we found that present self-efficacy, the knee strength test and the hop performance test, they all predicted the achievement of symmetrical muscle function independently. Okay, and then we were thinking about the psychological outcomes and profile. Is there a difference between the adolescents and the adult patients? So we did compare them again, the adolescent versus the adult at 8 and 12 months, with respect to psychological readiness to return to sport, knee-related self-efficacy, and motivation and goal setting. And we found that the adolescent athletes, they reported higher knee-related self-efficacy at both follow-ups. And in this study, they had a higher return to sport rate at both follow-ups. And there were no difference in psychological readiness to return to sport or in motivation and goal setting between the age groups. So the question was, what have we learned about adolescent athletes? And the majority of the patients, they return or make an early return to sport. And less than 1/3 of the patients, they achieve symmetrical muscle function in the patients that already had returned to sport. And athletes and now it's this age group, 15 to 30 years of age. Those with asymmetrical muscle function and with lower levels of self-efficacy, and they may need more than 1 year to achieve symmetrical muscle function. And then that is important for us as clinicians to know. And yet we don't know how to consider the difference between adolescent and adults with respect to self-efficacy. Thank you.
Thank you, Susanne. Now let's see if we manage to get Christian's presentation. Christian will be talking and giving us another breakdown on laxity and what it might mean and how we should maybe be thinking about this in clinic.
So, Beighton score, knee joint laxity. Why should you always think about this? And what is it? Well, if you look at laxity manually and instrumentally, you have different kinds of methods to assess it. And anterior posterior, everyone knows how to do Lachman. This is the most common test we use. It's just straightforward, back and forth. You see the movement between the AP plane, between the femur and the tibia. And the other one is the instrumental with KT1000 and roll meter, which we use in the instrument, which is quite useless actually, because it depends on which arm you use, how much leverage you use, and so on. It's quite destroyed by Swedish researchers, Ninni Sennett amongst others. Highly non-reproducible. And you have the rotatory component of it as well, which is the pivot shift phenomenon, which we really can describe precisely, but more that there's a rotation in the lateral compartment, which is why people are doing lateral exoculomesis nowadays. And we also know that some people have high increased joint laxity. And these people, they pose a problem for us. And in 1973, I think he's actually researchers in rheumatoid arthritis who published a study in an African population in former Swana, I think 1,070 patients, something like that. And he made it like a scoring system with 9 points, and he assessed 5 synovial joints. He actually excluded MCPs and so on because he realized there was no difference in MCP joints. And this is the study. So this is from 1973. If you read it, it's actually not that nice to read because it has nuances from that area, like, well, I'm not going to even say it, but it's still a study that is quite large cited. So how do you do this? Eleanor, just come a second. So if you come to my clinic, if you're in Sahlgrenska, you meet me. In the beginning, I actually did this. Hi, my name is Christian. Nice to meet you. So can you stand straight? Okay, can you reach your heels? Oh, great. Thank you. Finished. That's it. So how many points did she have? So
Probably not.
terrible, wasn't it? Okay, thumb. Reaching. One finger. Hyperextension. Hyperextension in the knee. And she could almost reach. Did you reach? Yeah.
What?
So, how many points? 9. 9 points. How many revisions have you had? You mean
2.
2.
So 3 ACL.
And is it broken?
Yeah.
Okay. So, do you have a problem? So you were a national level soccer athlete. And you got 9 in Bayton. 3 re-ruptures. 2 re-ruptures. So, does she look unfit to you? No. So there's a problem, isn't it? What's her problem? Well, probably the high-grade knee joint laxity she has. And how the knees are standing, and the hyperextension, but also the quality of her ligaments. So, who did your surgery?
There were 3 different surgeons.
Okay. And all of them are professors and so on. Mostly one of them. One of them was a professor. So he probably did the right thing maybe. So, okay. So it doesn't really matter who does the surgery as well. It poses a high risk. But where do we find these high-grade laxity people? Well, in the Western population, it's not that much actually. They say 10%. In other population ethnicities, which they talk about or Bayton talks about in his study, it's much higher. African population, Hindu population, and so on, much higher actually. And you see in young people more than old because you get stiffer the older you are. That's one of the things you can tell the people when they have a high-grade knee joint laxity. You just tell them you will get better when you get older and stiffer. You don't have to do anything and you will just get better. And female, well, some studies are showing that females have this more than male. Some studies are actually saying no. It's a little bit turning to against that female probably have it. And there are different ways to assess general knee joint laxity, high-grade laxity in joints, but Bayton is still the most common, even though it's so old and it's not really that well done study actually. The cutoff, I would say usually 5, but some people use 4 for the scoring. And if you look at the differences between a disease and just benign hypermobility, you can see that there is some connective tissue disorders, ehlers-Danlos, osteogenesis imperfecta, LD syndrome, and Marfan syndrome. But most people, they just go up there. Generalized joint hypermobility, and that's it. We don't find anything else. There's nothing wrong with you. You're just born this way. The problem is, are you actually fine? We're really sure there's nothing hereditary component in this. Oh, well, I think it is. I think we have alterations in the protein. And probably are some genes to this, because there's always a parent who has the same thing when you talk to them. And the penetrance is quite high if you look at it. So, if you look at the injury rate, you can see the failure rate from these 2 studies. I don't know how to pronounce it. Ushrak, and Larsen. You can see it's quite high. We think it's this. This is dense connective tissue correctly with correct alignment. This is what most people have, except Eleanor. Because Eleanor's is probably like this. So the alignment of the connective tissues is probably not like this. It's probably more like this. We don't know yet. We're doing a study on it. And if you look at the immune history, it actually doesn't look like this. It looks more like this portion. Like a very bad map. And thickness and quality of fibers. they're probably thinner. We don't know. So we do research. What we do know is these patients pose a problem. It can cause a career-ending disease for them, multiple surgeries, with good surgeons who still cannot restore previous knee function. So this is the next talk. Sorry. Okay, any questions about hypermobility syndrome? No?
We'll just save the questions for later.
Oh, okay. So.
You have to share.
Thank you, Kristen. And it's time for Eric to enter the stage again, and I like, we have to thank him and Andreas. Where are you? Stand up. Andreas, for the excellent game show last night and the entertainment. We'll give them a big applause. And it's time for Eric to tell us a little bit more. How far have we come with the non-reconstructed patients? Go ahead, Eric.
So I'm going to start out with a non-reconstructed patient. I think you and me agreed on this when we discussed the paper, the BDSM paper. The non-reconstructed patient is a patient who has not had an ACL reconstruction, but we really don't know what type of rehabilitation they've had either. So we don't know the quality of the treatment they had. And they might have had other types of surgery, so we're calling them a non-surgical patient would be misleading. And we talked briefly about this yesterday, one of the best trials of theirs, just saying that not having an ACL reconstruction is an option for a certain patient, and it is a treatment that will work. There is, and this is also with regard to the return to sports, that they might as well, or just as well as a patient having surgery or surgical reconstruction, return to sports. In a Cochrane review, which only includes the Forbel trial, which I showed on the first picture, they say, well, we have to be maybe not having surgery is not for everybody because there is a large number of patients switching treatments. So, as I said yesterday, I think, we say that 50% in Scandinavia have or go on having ACL reconstruction, 50% do not. We don't really know who. In Gothenburg, the numbers are different. So we have 85-50% relationship. So we really don't know why people get certain treatments. We have some ideas, but if we read the literature, it's just not out there, and we really don't know who benefits from the respective treatments. And the reality is not as good as in the Forbel trial, where we randomized patients looked sort of just alike. Because we looked in Claire looked in our registry, which Eleanor mentioned briefly, that, well, there are some differences if we ask them about their knee function with the KOOS, which absolutely has its limitations. So we want to take this one step further, and we're going to start looking within Project ACL, because we have a little bit more. We don't only have the KOOS, we have some other outcomes as well. And just looking at how these groups of patients look, we have 313 patients right now, which are treated without an ACL reconstruction. There's just the proportion of women and men is sort of alike. The big difference is with regard to age. There's almost a 10-year difference in the average age for these patients. If you look at, which is kind of interesting, we're going to start analyzing this data. If we looked at the strength measures they do, the blue-ish lines are the non-reconstructed patients, and the yellow and red line are the reconstructed patients. So you can see they actually recover their strength quite a bit quicker, and the undergoing ACL reconstruction Well, they don't really catch up until 18 months after the reconstruction. If we look at the HOP tests instead, numbers look a little bit different. This is also, you also have to keep in mind that we don't really do the HOP tests on all patients which are treated non-reconstructively. But as you see, it's around the 8-month mark, patients having the ACL reconstruction will appear to be just as good or slightly better than the patients not having reconstruction. Also interesting, if we look at some of the patient-reported outcomes, if we look at the KOOS, the quality of life appears to be quite similar. Looking at the sport and recreation, so the function in sport and recreation, there is a slight difference which starts to occur around the 8-month mark. We don't know if this is good or this is bad. If we look at the knee self-efficacy scale, there is quite a big difference. And we've seen from Pia, who's here today, in her studies, that we can work with the patient's knee self-efficacy. And I'm a bit surprised on these numbers, especially looking into the future, that they don't seem to change that much over time. But I'm a bit worried that we might be telling the patient who has undergone non-reconstructive treatment a bit different. We're helping them set different expectations, which might be good to a certain extent, but I think we have to rethink a little bit what we're saying, because we really don't know the outcome as well, or the future for these patients. So to sum this up, in clinical practice on Project ACL, non-reconstructive patients appear to be older. Non-reconstructive patients recover strength quicker, but not HOP performances, if we look at our data. Non-reconstructive patients appear to report inferior patient-reported outcomes, not across the board, but there appears to be differences, and I think we can work on this. And we need to learn more who does well after the respective treatments, and this might help us to help our patients in a better fashion. Thank you.
Thank you, Ian. Very good. And we ask Eleanor to come up again. She'll let us know more about the revisions and the contralateral surgery.
Yeah, I could probably talk about my revisions as well, now that you know that, but I won't. I'll take this chance to present some of our latest data and research on this area, and mostly unpublished data. Yeah. So to the right, we have these high rates of secondary injury. 1 in 4 young patients return to sports. That keeps following us. Despite that the ACL really has been meticulously investigated. But maybe we should zoom out a bit. Because we know that the knee is much more than just the ACL, and do isolated ACL injuries exist? They do, but they are rare. This study reported that only 12% are isolated, meaning that 88% of all ACL injuries are in combination with other structures. So we are interested in what effect on the ACL and on the risk of revision and contralateral injuries may an injury to an other structure have. Look, for example, at the MCL here. According to this study, 39% of all ACL injuries occurred in combination with the MCL injury. And isolated MCL injuries have good healing potential and are often treated conservatively, which is also many times the case when they are combined with an ACL injury. But it has been shown in cadaveric models so far that MCL deficiency increases the forces on the ACL graft, which may cause impaired healing of the ACL and may predispose graft failure. So if the MCL is not completely healed, it may have a catastrophic effect on the ACL. So we asked, do patients with non-surgical treatment of a concomitant MCL injury have an increased risk of ACL revision? And we found that they have. As you can see in the upper row here, patients with an isolated ACL injury and isolated ACL reconstruction had a lower risk for revision compared with patients with an ACL injury and a non-surgically treated MCL injury. Interestingly, there was no difference when the MCL was treated surgically with either suture repair or reconstruction. And this finding could possibly be due to some residual laxity when leaving an MCL injury untreated, putting more strain on the ACL. But a factor that actually seems to protect against both revision and contralateral injuries is cartilage injuries. Studies from our group have shown that concomitant cartilage injuries reduce the risk for both revision and contralateral injuries by about 25 to 30%. So is it good with cartilage injuries? Of course not, but it could be a proxy for activity level, which we unfortunately don't have data on. But with severe cartilage injuries, patients may modify their activity level and thereby be at a decreased risk for a new injury. And to further elucidate how cartilage injuries and other concomitant injuries may impact ACL revision in particular, we have looked at the injury pattern between the primary and the revision surgery. And for this, we used a population that had undergone both primary and revision surgery to compare the course of concomitant injuries between these occasions. And worryingly, during a short mean time of less than 3 years between the surgeries, cartilage injuries increased both in prevalence and severity. And we found a fourfold increased risk in PLC injuries, the posterior lateral corner. And cartilage injuries did not impact the outcome after ACL revision, but PLC injuries predicted worse coups after ACL revision with a detrimental effect, as you can see to the right, resulting in up to 30 points worse coups scores and almost similar numbers in quality of life. In fact, the PLC area was once called the dark side of the knee because injuries here were so often missed. And the causes for the increase in PLC injuries in this study at revision, they are unknown, and there was still a small proportion of patients having PLC injuries. But considering that it was a slight increase and that failure to detect PLC injury has been shown to result in a laxity pattern that may cause or predispose graft failure due to this laxity and forces on the ACL, it's not unlikely that some might have been missed at the primary surgery. And regardless, it had a strong negative effect on outcome after ACL revision, which indeed motivates us to further research of this area. So we must remember that the ACL is dependent on other stabilizers, and residual laxity caused by deficiency or injuries of other structures may increase the risk of a second injury. And therefore, of course, we need to perform a thorough assessment to detect such injuries and adapt both surgical treatment and rehabilitation protocols accordingly. Thank you.
Thank you, Eleanor. Very good. We ask Eric back again, and he's going to see if there are any long-term predictors. Everybody is aware what a predictor is. It's something you investigate early in the process to tell what the future is going to look like. And here we go, Eric.
I'm just going to give you a crash course at this, just to save a little bit of time so we can discuss a bit more. And I'm going to talk about our 10-year analysis from the Swedish registry, where we tried to identify risk factors for having inferior patient-reported knee function at 10 years after your reconstructions. And the key points of this study were, now I skipped the method section, so Christian's probably going to be a bit mad, but I skipped that part. If you had a grade 3 or grade 4 cartilage pathology, that was a risk factor. If you had lower levels on the KOOS, so saying if you had more preoperative pain before your surgery, you would have inferior 10-year outcome in the KOOS. If you had more limitations in ADL, this had a negative impact. And if you had a higher BMI preoperatively, that would affect or put you at risk from inferior KOOS. And all these risk factors were significant across 3 or 4 KOOS subscales. so it impacts quite a bit of them. And this is independent of, I'm just saying inferior, so I'm not saying what is good or what is bad. But interesting, as Eleanor presented from, which we know from Norway, is that what we have, we can actually, in a meaningful way, we can affect both the perceived pain on the COOS and the limitations in ADL. And if we now COOS has its limitations, but if we look at it, it appears that what we do in rehabilitation has a bigger impact than changing screw or changing graft has on the outcome, which is good. But then what we also may have to remember is that this is from the MOON trial in the US, where they have, this cohort here, they have 1,500 patients or so. And if you look at the COOS scores, they are from 2 years to 10 years, they're just about similar, which is kind of scary in a way, but maybe it's a good thing. Thank you.
Thank you, Eric. And we move on to Jon, what is the future? You have a crystal ball? Please let us know.
What we are working on in Gothenburg and which studies we might come up with in next, so to speak. So I'll try to make it quick because we need some time for discussion. What we are working on actually is several things, and we have several PhD students who are working in our group, like Torkel, who's going to defend his thesis in April, Eleanor also. So the things that we are working on is combination of ACL and other ligament injuries, how the outcome is after multi-ligament injuries, and how it differs from isolated ACL injury if an isolated injury exists. We are looking at the revision, ACL reconstruction, and the injury pattern and predictors of outcome, as Eric was talking about here. We are also looking at surgical predictors. What about the graft fixation devices, and also the learning curve, which we have found to be very interesting thing. I mentioned the ACL injuries in pediatric and adolescents. Not going to talk about that anymore. And also, we are going to explore the non-reconstructed patients even more. We like to understand, and we have actually a study in our next PhD student, Torkel, who will defend in April, about how the outcome is influenced by body weight. And this is also something that's interesting, and we found out that this is very, very important. We need to understand how we can increase our understanding of which COOS subscales are useful, and we have some doubts about some of the COOS subscales, and now recently in literature, COOS has been reduced to COOS 4, where ADL, activity of daily living, has been dropped because of the ceiling effects, and this is an ongoing problem with using this score. We are working together in the Scandinavian registries and the project ACL, Project Korsband, and what we are going to try to look into is about psychological factors in the treatment of patients with an ACL injury. And because we have so many patients who are operated in Gothenburg, we can actually do this locally. We will also check on the physical performance test after ACL reconstruction and compare with the non-reconstructed patients. We have an ongoing histological study to see if there's a difference in the collagen structure in patients with generalized joint hypermobility, and this was something that Christian mentioned in his talk, and this is the main focus for our PhD student David Sundemo, who will defend his thesis in a year or so. We will determine if the collagen in the hamstring tendons differs from patients with differs between patients with joint laxity and patients with normal mobility. And maybe we should have an individualized choice which graft to use and how to treat these patients. We are also looking at, and this is also something that David Sundermo, he will not include this in his thesis, it will be probably part of another thesis, another PhD student. We don't have the name of this student yet, but this is an ongoing project where we will collaborate with other registries and see if patients who sustained an ACL injury or severe knee injury have higher risk for diseases like myocardial infarction, coronary disease, stroke, diabetes, etc. And we have the tools and we can do this, and we will do this in close future. So the most important projects I would say is about children, adolescents, pediatric ACL, collaboration in Europe, and surgical technique on lateral extraarticular tenodesis. That's all. 5 minutes late.
Thank you. We will do like this. You go out, you take some coffee, have a little break. You come back with your coffee. We're going to set the stage with all the speakers, have questions, and we're going to end up that discussion with asking the orthopedic surgeons what they want us physical therapists to do better. And then we can tell them what we want them to do. So take a quick break, get some coffee or something else.
No, not so much like that anymore.